That was great. Thank you so much, Dr. Powell. I learned a lot. It's amazing. It goes back so far. But now we will dive into, now that you have that background, actually what we're about to dive into is the session that almost everyone expressed the number one interest in on their interest form that we filled out. And I just have to say, we have the most amazing community of scientists and clinicians, and I mean that, and other cancer communities actually say that as well. But we've brought together truly a rock star panel of leaders, of doctors, and of clinicians and researchers who truly are passionate about research, they're passionate about taking care of their patients, and I always say they're my Hollywood. Like, that's except Jason Bateman, I'll always love. But really, all kidding aside, they are my Hollywood. They are leaders, and I can't say enough great things about them. We're incredibly lucky to have them. And the moderator of this session, who also happens to be my oncologist, Mary Jo Fiedler, will be the one who introduces them. So Mary Jo.
I'll click.
Okay.
Is that okay? Yeah. So I'm honored to be here at the First Patient Summit. This is, so exciting, and what a great turnout, and what a great keynote speech. And I think we have a great panel. So the first part of today, at this point, is understanding and navigating the EGFR lung cancer treatment landscape. This is going to be recorded, just as an advisor. If you have any concerns, you can speak with the staff. So our goals for everyone here for this session are to understand the EGFR positive lung cancer and why it matters in changing treatment. And, we heard a pretty remarkable history of EGFR, but we'll break it down a little bit, too, in preparation for some of the data slides that we'll see. We'll also understand the pros and cons of different treatment options, and we'll have an overview of key trials and treatments that one may be better suited for than another, and some of these slides are pretty dense, so we'll be spending a lot of time on each. Excuse me? Oh. Yes, and I think we have a slide with the glossary of terms, but there is a glossary of terms form in the packet, which I think will be helpful to go back and refer. So we'll try to take our time with this, and please, raise your hands if you have any questions, or we get a little lost in the shuffle here. And then, the big goal is to feel more confident in asking questions to physicians and making decisions about your own treatment and helping others do the same. This is the QR code to submit questions online. And the second part of this morning is a panel question and answer. This QR code will be shown again, so don't panic. You can also ask questions in the room. So that was my welcome. And again, it's a really great honor to be here, and I'm excited to spend the next couple hours here. So I'm going to go through, this is the introductions for our panelists. We have Dr. Christine Lovely, who will be at the City of Hope Cancer Center in California coming up. Dr. Joshua Reese, who is a thoracic oncologist at Georgetown. And we have Dr. David Carbone, who comes to us from Ohio State. And we have Susan Scott, who comes to us from Johns Hopkins, and Samuel Kim, who comes to us locally from Northwestern for thoracic surgery. So just some, basics for EGFR. We definitely heard a lot as we talked about. And the EGFR stands for the epidermal growth factor receptor protein. And it's a protein located on cell surface. And I just want to point out that cancers aren't the only place that have this protein located. So as we hear about some of the potential side effects, for treatment, it is, usually related to crosstalk with proteins that we're not trying to get at, but that live in the body. So the EGFR protein is in a lot of places in the body and also in other tumor types, but in particular it lives in the lining of the mouth and the lungs, it lives in the colon, it lives in the skin. So with that background, you might understand why we may see some side effects appear when we try to target this protein. So the EGFR gene mutation is a gene change in the genetic material or DNA that encodes for this EGFR protein. So the protein it's a cell surface receptor, so there's a part on the outside of the cell, and then there's a part that continues inside of the cell that does all of the signaling. When you have a gene rearrangement, then the protein can signal much more easily and cause cancer cells to grow and is thought to be the driver of the cancer. So when I think of a cancer driver, I think of it as a superpower of the cancer. So, Superman can fly, but he also needs to use energy better and hide from the immune system and do all of these other things to stay in flight. But the EGFR protein is the main driver of the cancer for these driver-related lung cancers and has been a great target that we've been able to use. For EGFR, there are what we call the common EGFR gene mutations, and those are what you heard about the previous talk, exon 19 deletion, and in exon 21, the L858R point mutation. So these are the bulk of the genes that we can target for EGFR-driven lung cancer, and the gene change is what shapes and drives the protein to behave differently. And there's some very interesting work that we've seen that can show how different gene changes in the EGFR gene, which spans not just exon 19 and exon 21, exon 20, exon 18. So different parts of the gene can have a change in it, and the shape can be a little bit different. And there's some subtleties with how it drives the cancer and how we can better target it. If you don't have one of the more common EGFR gene mutations, the uncommon mutations, there are many, and there have been some work to try to tease out what treatment options might be better for some of these uncommon mutations, as there are fewer of them relatively, but they do make up a big group overall. So the treatment options for someone who has EGFR mutated lung cancer, it goes back to the kind of mutation you have. So the common mutations, we have EGFR tyrosine kinase inhibitors approved. The vast majority of people here start with the third generation drug approved in the US, which is osimertinib or Tagrisso. And the idea is that these small molecules can go inside the cell and jam up the signaling pathway that is an overdrive from the EGFR gene mutation. We do know that cancers can continue to grow, and that's a feature of cancer, is continuing to evolve, and sometimes the evolution allows the cancer cells to outsmart what we're doing. So that is what we typically call acquired resistance, and we'll see some information about some what we call second line treatment strategies. So if the first treatment strategy has stopped working, then we do try to see how the cancer is growing and the method of the acquired resistance. And one way we do that is to recheck the gene changes in the cancer cells and see if we have a new target, another biomarker that we can use. So in addition to the tyrosine kinase inhibitor pills, we can use combination therapy, which means that the tyrosine kinase inhibitor is the basis of the treatment, but we're adding something to it to try to make it work better. We've seen some dramatic pictures in the last half an hour where x-rays can really clear up and patients can feel so much better so quickly. But we don't always see the outcomes that we like, and we don't always see it lasting long enough. So that's the idea of doing combination therapy, to add something else that works with the hopes of lowering the amount of cancer clones and cancer in the body to have it delay the time when someone needs to do the next treatment. Second-line treatment can be various things, and we'll review many of them that are options now. They can be chemotherapies, they can be new targeted drugs, they can be antibody-based therapies, and whether they're antibody-based therapies that attack the cell signaling or antibodies that bring chemotherapy directly to the cancer cell, those are ways to treat the second-line resistance, and we'll go into more details with that. And we do have some discussion about early versus late-stage treatment. We are blessed to have approvals for drugs targeting EGFR in all stages of EGFR mutated lung cancer. So for early stage, depending upon the tumor size, we can use osimertinib or Tagrisso after surgery. For patients who have a little bit more advanced disease, but not where it's spread outside of the chest, we can use radiation and also use targeted therapy after that. But in general, these targets have been so important in patients with EGFR, where at the beginning of the story you heard, we were really only using them for patients who had cancers that we couldn't cure and were trying to turn into more of a chronic illness. So now we have expanded uses for these drugs, and it's been a really exciting place to be for oncology. So I talked briefly the tyrosine kinase inhibitors. They're little proteins that go inside the cell. They're oral medications, and they jam up the signaling pathways. Antibody drug conjugates, I alluded to. Antibody drug conjugates, we talk about it as kind of a fancy chemotherapy, because they do have chemotherapy. The drug that's attached to the antibody protein is chemotherapy that usually is not very well tolerated if you were to give full doses to circulate through the whole body, but they're attached to a protein, and there's a little linker that attaches the chemotherapy to the protein, and the protein is drawn, because of its features, the protein is an antibody that's drawn towards where the cancer is. And then something about the environment of the cancer can release the chemotherapy away from the protein. So we can see these drugs work better with a little bit less side effects than we'd expect with just using those treatments. Bispecific I alluded to as well. So there are antibody therapies, and this area is really a big area of development. And there are antibodies that have two arms. So you have an arm that's going for the EGFR protein, or a protein that's frequently seen on EGFR mutated lung cancers, and then the other arm is trying to do something else. So we've made the most progress with the other arm going after the MET protein. MET is a common resistance pathway for EGFR mutated lung cancer that's seen osimertinib, or these third generation tyrosine kinase inhibitors. So targeting the MET protein can improve cancer control, and there's no chemotherapy attached to many of these bispecifics, although some of them, even in later stages, new developments, have everything, different proteins, antibodies attached to it. So it's an evolving field. There are some antibodies that are trying to really figure out how we can use the immune system better, so targeting EGFR protein and bringing specific aspects of the immune system to the cancer, because we haven't seen immunotherapy in general work as well as we would like for this kind of cancer. But really, I think the bispecifics is definitely an area to watch. So I think we can move on to our panel presentation, and I believe Dr. Lovely is starting first. Oh, and actually now would be a good time for the whole panel to come up. And we all have microphones. We saw your pictures briefly, but if you could introduce yourselves as down the line. Dr. Carbone's taking the last seat or the first seat?
That's yours.
Okay. So let's start with Dr. Scott.
Hi, I'm Susan Scott from Johns Hopkins. Great to be here.
Hi, I'm Christine Lovely. I am currently unemployed between jobs. So I just finished at Vanderbilt this week, and I'm moving to Southern California. I'm very pleased to be here. Thank you so much for having me.
Hi, my name is Sam Kim. I'm a thoracic surgeon at Northwestern.
I'm Josh Royce, thoracic medical oncologist at Georgetown in Washington, D.C.
And I'm David Carbone, thoracic medical oncologist at Ohio State. And I have to say, I don't know if William remembers, but I was at Vanderbilt and I flew up to Manhattan to have breakfast with him to try to convince him to come to Vanderbilt, which he did. So, I'm pleased that we were able to work together for a while.
Okay, so the first topic is frontline treatment options. And Dr. Lovely is starting with those.
Okay, so hi everyone. I'm so delighted to be here. I am going to take a step back and say three things before I start talking about trials. First, this, as you all know, medicine has its own language, science has its own language, and sometimes the terminology we use can feel foreign and overwhelming. Please, 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 whenever you feel like your doctor or your care team is using the medical language instead of like, hey, explain this to me like a real person, tell them it's okay to pause and like, hey, explain this to me like in real words. And if there's anything you want to ask any of us today, please find us during the breaks or just come. I'm sitting in the back because my computer doesn't work without a plug-in. So please come and find me if you're like, Christine, I just really want to understand what this word means. I'm delighted because this is a completely different language. We go to school for years to learn this language and expect patients to walk in the front door and understand. That's crazy. And so please, 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 never feel like you should walk in and be like, this world is overwhelming and it's stressful, and please, like, find us if you're like, I just want to understand what this means in an informal way. The second thing is, you're going to hear about a lot of trials today, and you're going to see all these curves and hear all these words like flora and Mariposa, and to me, it's amazing, and I love William's slide, Dr. Powell's slide. I call him William because William was my mentor, and I'm so grateful for that. And David was mentor, and I'm so grateful for that. And we are only here because we stand on the shoulder of giants, and amazing. But these trials, these slides that you'll see, these Kaplan-Meier curves, each one of those bars is a patient. And I think it's so important for us to recognize, acknowledge, and applaud that because as Dr. Powell's slide showed, no research, no trials equals no cures. We cannot advance treatment paradigms if we don't actually have these trials, period. We get stuck at where we are if we don't have trials. And so advancing research is so incredibly important. And the last thing I will say is, there are two simple things you should know about me. I love cancer and I love dogs. And so if you love dogs, please show me your dog, particularly rescue dogs. And I think it's nice to be relatable. And so yes, please, if you want to talk about cancer or dogs, find me after. Okay, so I'm going to talk to you about Flora, which was the first trial of osimertinib. And before I even talk about Flora, you've heard several times, but I think it's good to reinforce, all these different EGFR TKIs, or tyrosine kinase inhibitors. EGFR is an engine or an enzyme. That's the medical word, enzyme. I'm going to call it an engine. And it has a function. And what these drugs do is just block the engine from working. And there's multiple different, what we call generations of drugs. The first generation was erlotinib and gefitinib. You heard Dr. Powell talk about those. The second generation, afatinib. You heard Dr. Powell talk about that. Third generation, I'm going to talk more about osimertinib. Why do we develop these generations of drugs? Well, really, this is science in its best form. Every different generation of drug gets better because we learn. Every successive generation, and this is not unique to EGFR as well, every successive generation gets better at targeting EGFR. That's good. We want to turn off the engine. It's really that simple. Turn off the engine. And more important, or equally as importantly, we want to be able to get the drug to go to the brain. The brain is a sanctuary site in cancer medicine and in medicine in general. And so as the generations of drugs proceed, we get turning off the engine better inhibition of EGFR, and we get better ability to go to the brain. Osimertinib was transformative for so many reasons. It was the first drug that actually was very selective against the mutated EGFR. The other ones, the other generations, erlotinib, gefitinib, afatinib, targeted the normal EGFR that we all have in our body in multiple different places. And that was a great start, but it wasn't good enough. Osimertinib was, hey, we're going to take the mutated EGFR that's in the cancer and specifically make a drug to target that. And so this was the trial, osimertinib, the FLORA trial, compared osimertinib to what was considered standard of care at that time, either erlotinib or gefitinib. So basically, the question was asking, hey, if we take a third generation drug, osimertinib, which was selective against the mutated EGFR, and we treat patients with that drug versus the first generation of drug, erlotinib or gefitinib, which one produced better outcomes? Now you may be thinking, well, Christine, that's ridiculous. You just told me you're making better drugs. So why would you even have to compare them in a prospective, moving forward clinical trial? Well, because we have to test it rigorously. We don't just start giving drugs sort of willy-nilly to patients in the clinic. We have to ask the question and do rigorous science because people's lives are at stake here. And so in this clinical trial, it tested osimertinib versus erlotinib or gefitinib, and osimertinib, as many of you know, is given 80 milligrams once a day. And the way this came to be is basically the osimertinib, not surprisingly, was superior outcomes, progression-free survival, which means the amount of time a patient is on the drug before the cancer starts to progress, compared to the older generations of drugs, erlotinib or gefitinib. So let me take a step back and say, this was a huge advance forward. It told us science leads to better drugs, leads to better outcomes. Degreso, osimertinib, was better than erlotinib or gefitinib. It led to longer times for patients being on drug. It led to better outcomes. It led to, hey, a patient can stay on this drug, Tagrisso, longer. It led to longer overall survival. But I would strongly argue, as I imagine pretty much everyone in this room would argue as well, is 18.9 months enough? Absolutely not. And so this was a huge step forward, but it's not, it's only a step. And so you'll hear from all of us about next steps. This was a huge leap, this FLORA trial that brought us osimertinib in the first line, that gave us the ability to deliver a drug that not only had these properties of being more selective against EGFR, having better brain penetration, but then gave us better outcomes, better quality of life. So because it's a better EGFR inhibitor, it had less toxicities than some of the earlier drugs. And some of the common side effects, although I would say, compared to the earlier generations, rash, diarrhea, some dry skin, but much less so than erlotinib, gefitinib, and afatinib. If you could advance to the next slide. So now we ask the key question. All right, we have this great drug, Tagrisso, osimertinib, and we're kind of taught to use not the brand name, so I'm going to often call it osimertinib. Osimertinib was at a step forward, but 18.9 months of being on a drug before the cancer starts to grow back is clearly not enough. So what do we do next? And that's really where we're at right now in terms of the cutting edge. If we say to ourselves, we have a good drug, how do we make it better? And what are the tools we have in our toolbox to actually make the drug better? One next step was, okay, let's combine osimertinib plus chemotherapy. And the two specific chemotherapies were either cisplatin or carboplatin, or medicines we call platins, with pemetrexed. This has been the backbone of treatment for advanced lung cancer for decades. Now you may say to me, and this is reasonable, well, Christine, we're talking about targeted therapies and very precise cancer care, and why all of a sudden are you talking about throwing in chemo? Well, let me explain. So I actually really like this regimen for the following. The EGFR drug, osimertinib, very specific to targeting EGFR, And I think about the chemo as sort of mopping up anything else that may or may not be responding to the EGFR therapy. And there are many reasons, and we can go deep down that well if you're interested. The way this trial was carried out was patients either received osimertinib alone, just the single pill, or osimertinib plus chemotherapy. And the chemotherapy is given as dosed every 3 weeks, and you get about 4 rounds of the platinum medicine, carboplatin or cisplatin, with pemetrexed together, and then what we call maintenance pemetrexed, given about every 3 weeks. And so the downsides are more clinic visits, infusional therapies, and all the side effects of chemotherapy, which I'll get into in a second. The upside is we saw that the addition of chemotherapy increased the progression-free survival. So if the progression-free survival, the amount of time patients are on osimertinib before their cancer starts to progress, is about 18.9 months, this increased the progression-free survival to about 25.5 months and increased the overall survival. So this is data literally on the cutting edge. It was just presented last month. So the average overall survival was about 4 years. So from the time patients were diagnosed, started on osimertinib plus chemo, 4-year overall survival for this regimen. Is that enough? Absolutely not. Do we need to do better? Absolutely. Is this a step forward using drugs that are our inner clinical toolbox? Yes. Side effects from this regimen, the osimertinib side effects, rash, some diarrhea, and chemo side effects. Lowering your blood counts, risk for infection. I would say these medicines, platinum plus pemetrexed, are ones that we dosed a lot for a lot of different types of lung cancer. Usually we can support patients through. And I usually try to give an expectation for, hey, if this regimen is like on a scale of 1 being sort of mildest to 10 being the absolute worst, where does this fall? That's kind of just to give an expectation. This is typically a regimen that most patients can get through in my experience. Is it a walk in the park? Absolutely not. But I think this was a major step forward and is one of the forefront regimens right now to continue to advance first-line treatments for patients with newly diagnosed metastatic EGFR mutant lung cancer. I will end at that. Please come feel free to find me, talk about cancer, all these crazy words, and show me your picture of your dogs. Thank you so much.
All right, so I'm going to talk about a third frontline option, which is called the Mariposa regimen, and this works with 2 different drugs. So lazertinib, I describe it when I talk to my patients about these 3 options as kind of a cousin of osimertinib. They're very similar. They work very similarly against the same types of mutation, those classical mutations in EGFR. They're both 3rd-generation EGFR tyrosine kinase inhibitors. Amivantamab is one of the bispecific antibodies that Dr. Fidler was talking about a few minutes ago, where they kind of hook together 2 different signaling proteins on the surface of the cell and help to block the signaling that way. The rationale for this, as Dr. Pao talked about a little bit before, was kind of targeting EGFR from the inside and the outside. So the lazertinib binds to the tyrosine kinase part, which is this intracellular part, and then the amivantamab binds EGFR from the outside, and also this other MET protein, which can help potentially prolong the time on these inhibitors. So this is kind of a dual targeted therapy approach. And with that comes a lot of caveats. So different types of side effects, different types of administration, which is what kind of the highlights of this slide are going to go over. This study was looking at patients who had never had treatment for their EGFR mutated lung cancer. So again, a first-line study. They gave the amivantamab, which is an IV medicine. It's given every 2 weeks. And then they took the lazertinib every day. This was compared to osimertinib because at the time this trial was done, osimertinib frontline or the FLORA regimen was our standard of care. And so this is comparing the combination of amivantamab and lazertinib to that osimertinib. The outcomes showed it was very similar to the FLORA-2 study, where they were looking at how long it took for the cancer to grow on treatment. And again, it was almost 2 years compared to about 1.5 years with the osimertinib. So again, an improvement in the progression-free survival. They also showed a little bit earlier this year that it improved the overall survival to equivalently about that 4 years. Things that are really important to know about this regimen. So when you kind of attack EGFR in 2 different ways, those side effects are amplified. So things that like the rash, in particular, the kind of cutaneous side effects, so nail changes, skin changes, those are definitely increased on this regimen compared to osimertinib by itself or osimertinib plus chemotherapy. There's a line in here about the later onset of symptom worsening. So compared to chemo, where we get symptoms pretty quickly, this one takes a little bit longer for sometimes these symptoms to show up, which is important when we're trying to evaluate it, when we're trying to prepare patients for what to expect. It's a bit of a different timeline. We can go to the next slide. And then a quick highlight about uncommon or non-classical EGFR mutations. Now, Dr. Lovely is my mentor in this space and has taught me a lot about it, but importantly, especially in a room where all we're talking about is EGFR-driven lung cancer, it's important to acknowledge that not every tumor has those two kind of classical mutations, the exon 19 deletion and the L858R, and that when we kind of drill down into the subgroup of EGFR mutated lung cancers, about 15 to 20% are driven by other types of mutations where osimertinib or osimertinib and chemo or amivantamab and lazertinib don't necessarily work as well, may not even be FDA approved. Some common types of these non-classical mutations include exon 20 insertions, this list of letters and numbers here, which are other types of non-classical point mutations, and then some tumors even have 2 EGFR mutations in them. The Papillon study on the right highlights a drug regimen for EGFR exon 20 insertions. So this is utilizing that amivantamab bispecific antibody with chemotherapy. And the idea here is that if the tyrosine kinase inhibitors that bind that intracellular part can't work because the shape of the exon 20 insertion mutation, that protein's just shaped differently. So those molecules don't bind, but the outside part looks very similar. And so the amivantamab can still work. We combine it with chemo to kind of give an amplified response in the front line, and this has become our standard of care. They compared it to chemo by itself with the addition of amivantamab, and that addition of amivantamab for this specific subtype of EGFR lung cancer demonstrated an improvement in that progression-free survival or time before the cancer started growing again, up to closer to a year, compared to about 6 to 7 months. They also had a higher rate of response, meaning tumor shrinkage, as Dr. Powell told us about, and this is now our approved first-line therapy. With all the EGFR toxicities, we worry about all the EGFR inhibitors, we worry about skin and nail toxicity, swelling or edema, and then amivantamab, and I should have said this in the last slide, because it's an antibody, and it goes straight into the vein, sometimes, very often I should say, 2/3 of patients experience an infusion-related reaction on that first infusion, which can be very scary. It's something that we usually get through, but it's really important to prepare patients for, and it's something that is an important feature of this regimen. It also, the chemotherapy side effects, as we mentioned, the low blood counts and fatigue are important to consider.
All right. All right, so I think we're moving on to second-line treatment, and if it wasn't confusing yet, it's getting a lot more confusing now. But I will say that's actually a good thing, and the reason I say that is because, not even 5 years ago, what we started with here was osimertinib. We say, here's a pill, this is what we're starting. And after that, there wasn't a lot of options. We would obviously want to profile the tumor, and we'll talk more about that. And if we found a certain bypass pathway of why the cancer is still growing, maybe we could target that. But outside of that, there weren't a whole lot of other options. And now we're entering an era where we do have a lot of options. So it's very dependent on what one receives first, how that cancer is growing. And so it is a confusing kind of choose your adventure pathway. But hopefully we can kind of demystify that a little bit. And again, I encourage you, use those QR codes on your tables, put questions in so that we could unpack this further. I think, though, there are two important, well, let me back up 1 minute. We know that these treatments, while again, as Christine said, as Susie said, we get a duration of period where the cancer is controlled, invariably the cancer, unfortunately, does grow again. These treatments are unfortunately not curative. We still need to get there. And what that means is that for really almost everyone, we're going to be talking about, well, what do we do next? And I think there are two important questions that come when you're facing this. It is, all right, how has the cancer learned to grow again? In what way is it now developed what we call a resistance to the treatment? And where is it growing again? Because those two features, those 2 points, really dictate kind of how we go to attack this. And so to the second point on kind of the extent of how the cancer is growing again, this is where we talk about here as we talk about oligoresidual, oligoprogressive, oligometastatic. So what does all this oligo stuff mean? So what that means is that we're seeing how has the cancer shrunk down and where are spots where it still is appearing to be persistent. So when we talk about oligoresidual disease, that means, okay, we've now given we're taking osimertinib or a combination therapy, and now there looks like there's maybe one or a couple spots that are still hanging on, that are still there that we can see on the scan. The second there in the middle, oligoprogressive, means, all right, we've had a period where we have good control of the cancer, and now there's a few spots that seem to be misbehaving, that seem to be acting up. And then oligometastatic, that is in some ways maybe encompassing both aspects, but that means is that perhaps when the cancer first was found, it's only spread to a select few other sites. There is no one clear definition in any of these situations. For example, oligometastatic has been described from 1 to 3 to up to 5, or even in some studies more, number of cancer spots outside of the lungs. But this is the patterns of disease, and it informs, on one hand, how we might want to attack the cancer, seeing it grow again. Just one more point, then we'll move on. I like to talk. So the second point here is, again, we want to understand why the cancer is growing again. And so that's why it is so important to do another biopsy of the cancer. And as infrequently as this, unfortunately, well, I would say not infrequently, but as much as this is not happening in everybody at the outset, it's even less when the cancer grows again. And so it's important as a patient, you know, if you're in your doctor's office, your oncologist's office, and we're seeing the cancer grow again, ask, you know, should we consider another biopsy? How are we going to, biopsy the cancer? Because we need to understand how that cancer is growing again to inform what we're doing next. It could be that there's now, that light switch that was turned off with osimertinib now is being turned back on through a different pathway. And maybe we can target that with additional pills or something utilizing, because we can see pathways in, for example, BRAF, in MET. So sometimes you can introduce a combination. Sometimes actually the cancer has transformed and it looks different. And now instead of a non-small cell adenocarcinoma, which we most commonly see, we can see a squamous non-small cell or even a small cell lung cancer. And so the treatments that we would recommend are really wholly dependent on what we see in that biopsy. And it's important to do a biopsy of the tissue and ideally also the blood biopsy, the liquid biopsy. You really want to try to get both. Obviously, a liquid biopsy is easier, but that alone won't tell you how that cancer it may be morphing, if it looks different, or kind of in the area that's growing, what is the unique alteration that's causing it to grow. All right, so that's my primer there. So I think we can go on to the next slide. All right, so let's say the cancer is growing in only one or a couple areas, and otherwise we're seeing good control. We can commonly see this, and the reason for that is that typically when one is receiving osimertinib, there are a lot of the cancer cells that are still being controlled very well, but it's an offshoot of that is now leading to seeing the cancer grow again, whether, again, that's a new signal being activated or the cancer now looking different under the microscope. But if this is something where the cancer is growing in one of a few areas, oftentimes, and again, we still want a biopsy, but oftentimes we can say, well, what if we radiate that spot? What if we even consider surgery for that spot? And if we do that, and someone is tolerating a treatment well, again, using that word very loosely, tolerating, but we can kick the can further down the road. We can see ongoing cancer control for a period of time before we need to change up the medical treatments that we are giving. So that's the kind of the thought behind local therapy. And again, typically either surgery or radiation. There are also some interventional techniques, ablation, you may have heard that word before, photoablation, chemoablation, radiofrequency ablation. But these are local treatments meant to kill the cancer centers in one or a few spots where they might be growing. Now, the second option, and the one that we're going to spend a little more time talking about now, is what if there's more widespread cancer growth, where we can't feasibly zap one or a few spots, and we have to talk about transitioning to another medical treatment. And I will say, invariably, this is something that we face with most of our patients, because also one doesn't know if a few spots are growing, is that a snowflake that then a flurry that goes away? Or is it a snowflake before a blizzard? And I think that that is something that we oftentimes have to try to combat as well. So we can move forward to the next slide. So what are our types of second-line treatments? And I'll say that we're going to first focus on what is either approved or I would say available, because oftentimes when we're talking about combinations of targeted treatments, I mean, are these combinations strictly approved? No, but they are medicines that are available, and they can very easily, I should say they're not approved in combination, but they're very easily available. There's a lot of data behind it and something that we frequently do. And so let's talk a bit about some of the treatment strategies that are approved and available after the cancer grows. And again, there is so much of a choose your own adventure here. A lot of this depends, what are you receiving first? Is it just the osimertinib? Is it osimertinib with chemotherapy? Is it the amivantamab medicine with lazertinib? Because oftentimes what that treatment is in the beginning will inform what you're going to do next. So to talk about what's available, so first Mariposa 2, you'll see that sounds like Mariposa 1, and that's because it involves some of the similar drugs. One is amivantamab, which again, as Susie mentioned, is this bispecific antibody, meaning it has one side that targets EGFR, the receptor, the surface, and one side that targets MET. And so this is a combination that combines that with chemotherapy in patients who have experienced disease progression on osimertinib. This is how at least it was studied. And then actually patients in this trial were randomized to either that triplet combination that I mentioned, chemotherapy or chemotherapy plus amivantamab plus lazertinib, so really a triplet or a quadruplet if you think of people receiving two different chemo medicines. And so what it found was that the combination of chemotherapy with amivantamab controlled the cancer for longer than just chemotherapy by itself. You could see on average for about 8.3 months versus 4.2 months. What was interesting is that in this study, still taking the pill, the lazertinib, did not seem to move the needle very much on that, what we call progression-free survival, both in the body and in the brain. And so that's why, at least for this regimen, the combination is the chemotherapy with the amivantamab. Another treatment that is approved and available is datopotamab deruxtecan, which is an antibody drug conjugate. And so Mary Jo commented on this earlier. What is an antibody drug conjugate? You could think of that as like a smart chemotherapy. Basically, you're trying to target the chemo to the cancer cells. It's made up of three key components: an antibody, which is what's targeting the cancer cell. Ideally, you want to target something that's selectively on the cancer cell or overexpressed on the cancer cell, because you don't want this to go to normal cells in the body. Then with a linker that's attached to a highly potent chemo molecule, more potent than the kind of classical chemo medicines that we give. And again, the idea is you're shepherding that chemotherapy into the cancer cell. So this was approved based off of actually pooled data from two trials, this Tropion-Lung-01 and Lung-05, looking particularly at patients with EGFR mutations and how they performed on the pooled from those two studies. And so what this showed was that the response rate, meaning the amount of patients that had at least a 30% reduction in their tumors, was seen in 43%. And people lived on average 6 months before the cancer started to grow again, and about 16 months overall. So again, these are the raw numbers there, maybe not what we need to see. We need to do better, but something that is available. And I will say, this is pooled data from I would say, single-arm data, in the sense that the data from this studies patients weren't enrolled specifically with EGFR mutations and kind of randomized and compared in a classical way when looking at kind of statistics, how we break down a study. And so because of that, while it's great to have an option we need more options for patients, if someone has not received a platinum doublet chemotherapy, in my opinion, I don't necessarily think this should usurp that yet until we have more data. So we can move on here. Sorry, there's a lot to unpack. So on the left, so one question is, again, for patients who take osimertinib, and the cancer starts to grow again, and we need to give chemotherapy now, should we continue the osimertinib? I think a lot of us kind of, just in understanding the biology of the disease, felt yes, one should, because there are places where osimertinib is controlling the cancer. But what this study looked at is actually looked at, should one continue osimertinib if you're going to add in platinum doublet chemotherapy? And the short answer is that this study suggests, yes, we should be doing that. Patients tended to live longer without cancer growing again if that osimertinib was continued. And in addition, there was enhanced control of the cancer in the brain. So let's suggest that if a platinum doublet chemotherapy is right as the next step in the treatment, that osimertinib Tagrisso should be continued in the majority of cases. Now, on the right-hand side of the slide, this is when I said about bypass pathways, like new signals being kind of activated and kicked on. This is something that can be considered. And what that is these two studies both looked at if patients who now the cancer is growing again on the EGFR targeted therapy, it's biopsy, and importantly, you need to biopsy here, but have a signal in this protein called MET. Either the gene is amplified, meaning there are more gene copies, or there's higher levels on the surface of the cancer. Can we add a pill that targets MET, and can that lead to sustained cancer control? And two studies actually showed that is possible. One, the INSIGHT 2 study, adding a MET-targeted therapy called tepotinib, and the study called Savannah targeting, the study called Savannah with the molecule called savolitinib. So what this showed is that, again, across these studies, we saw renewed shrinkage in 40 to 50% of patients, with the average time to cancer growing again being 5 to 7 months. All right, next slide. I know we're getting to the end of my time, and so now we're going to talk a bit about all right, well, what is on deck? What is down the road? And there are a lot of things even beyond this slide, but if we tried to break down every molecule in development, you wouldn't be able to go to Christmas. So, but these are two that are very, I would say, close, and actually in some cases with the evonescimab there on the left, approved in other places in China. So what is evonescimab? This is a bispecific antibody. So again, antibody targeting two things. One, PD-1. So this is immunotherapy targeting, similar to your Keytruda, your Opdivo. And the other side targeting VEGF. And I don't know if we have the time to go into the main backstory here, but essentially immunotherapies targeting this PD-1, PD-L1 axis have not been shown to move the needle in EGFR-altered lung cancer. I think we'll talk a little bit more later today about why that is, the biology of the cancer, and why it doesn't seem that these medicines are able to work well in this type of cancer. But there's some data, and there's been data back a long time, that if you target the PD-1, the VEGF, and then you also bring in chemo, that perhaps that can do better than chemotherapy by itself. And this molecule, evonescimab, is kind of the next generation of that, because again, it takes one molecule that targets PD-1 and VEGF together, adds that to chemotherapy, and asks, can this do better than chemotherapy in helping to control the cancer better? And so what this showed in a trial that was presented, updated trial that was presented earlier at World Lung this year, just last month, that this combination does help people to live longer before the cancer grows again, and that there might be, looks like a trend of actually helping people to live longer than just chemotherapy by itself. But where this molecule is going to fit into the overall story is challenging, because I already talked about combining chemotherapy with that amivantamab, that EGFR medicine, and a lot of patients receive this chemotherapy now up front with osimertinib, with FLAURA2, as Christine was talking about. So it's, again, a very muddy, complicated picture. And on the right is another one of these antibody drug conjugates, similar to the datopotamab deruxtecan, this one called sacituzumab tirumotecan, also targets a molecule, I know it's a mouthful, also targets a molecule on the surface of the cancer called TROP2. Again, this is the marker basically on the cancer cell that antibody is honing in, trying to bring that chemo molecule into the cell. And we actually saw data presented at a European Medical Lung Conference just last month that was very exciting, a phase 3 study that compared this molecule to platinum doublet chemotherapy. And this was a Chinese study. We want to look to see more data on this compound, but it suggested that patients lived longer before the cancer grew again compared to your platinum chemotherapy, and there was also a significant improvement in overall survival. So not just living longer till the cancer grew again, but living longer overall. So deep breath, that was a lot of things to cover, but what I want to stress is that, importantly, when the cancer is growing again, you want to know where it's growing, to what extent it's growing, and you want to molecularly profile the cancer again so that your physician and you together can determine what the best next step is for you in fighting this cancer. Thank you.
So before I give my portion of the talk, I want to say it's truly an honor and humbling experience to be here among all the clinicians, researchers, patients who survived the lung cancer or who are undergoing a treatment. I'd actually rather be here than being in a big doctor meeting, listening to this and that. Okay, so thank you very much. During the breakfast, I actually met one of my patients that I operated 4 years ago. And she looked, I didn't recognize her because she looked so good. And so when I first met her, I'm like, ooh, hopefully I did a good job. But she did tell me that we operated in the afternoon. She went home next day. She walked back to her home, which I think is about 3 blocks from here. So I must have done a good job. So why is the thoracic surgeon here in a meeting talking about EGFR mutation, lung cancer, right? So, for thoracic surgeon, 20 years ago or something like that, we operated early lung cancer, we operated, and oncologists will take a look at the pathology and then give some sort of systemic treatment based on, nodal status and so forth. For very late cancer or advanced cancer, we didn't operate on the patients, right? But that all kind of changed with now, and what's the role of surgery in locally advanced lung cancer, even stage 3B or stage 4 cancer. The paradigm is shifting now because there's a lot of more nuance that goes into it, especially given the fact that with the immunotherapy and with targeted treatment, those patients we thought that maybe not be a surgical candidate are now within the realm where we could kind of think about it. So in my talk, I want to kind of think about when is a surgery considered, and who are maybe the right candidate for surgery, what kind of operation. I mean, this will be very brief, and what are the sort of techniques that we have. Can we go to the next slide? So early lung cancer, I think there's, not a whole lot of debate. For patients who are, fit, early lung cancer, local therapies, I think surgery probably provides the best option for the patients. But is there a role for surgery in kind of more advanced lung cancers? So I think there's a lot of data sort of coming out, especially with this sort of a randomized phase 2 study that shows that what we call local consolidated therapy patient who had maybe stage 4 cancer, as we talked about, that got systemic treatment and then now achieved some sort of stability, but there might be a couple areas that really hasn't responded. They may be growing. What do we do with that? Because they're kind of achieving, resistance. Those patients who underwent consolidated therapy, whether through the radiation or surgery, versus just continue with the maintenance. There's data that now shows that doing a consolidated therapy shows a benefit. And then there's some additional paper that came out. What's the role in surgery? Because I think about 80% of these patients will get radiation treatment, but those patients, 20% of patients got surgery. They did remarkably well too, because it's not just medical oncology with these drugs that advance. Surgery in past 20 years has advanced significantly. And nowadays, with the robotic surgery and so forth, these kind of operations that people got thoracotomy and stuff like that, no, we're doing operation with a small holes. A lot of patients home go same day, next day, I think majority of patients go home within first couple of days with much faster recovery and almost no morbidity and mortality for these kind of things. So looking at some of these data that shows that surgical patients do remarkably well. But the key thing is who are the right kind of patient, and because we don't want to potentially operate on patient that may not benefit with a sort of a more invasive intervention. Next slide, please. And so, actually, I'm also one of the author on this paper. So, Society of Thoracic Surgeons, that's the biggest surgical society. I mean, majority of surgeons out there, thoracic surgeons out there, are part of this society. We created this practice guideline for managing these sort of patients with oligometastatic non-small cell lung cancer, because now we're actually getting involved with surgical management of these kind of patients. So I think that, it's now being accepted that surgery as a part of the conservative therapy could potentially give a therapeutic benefit for those patients with these kind of cancer we talked about. But what we are looking for is obviously, patient has to be fit, but that definition is what fit is getting pushed to the boundary, because patients are living longer but healthier, and then we're doing surgery that are less invasive, so patients are able to tolerate it. But for disease-wise, what we're looking at is the disease stability. So I think majority of surgeons, when we talk, I said probably about 6 months, at least a 6-month stability, and seeing what's happening with those metastatic disease process. In general, most of these studies that are done, probably like a less than 3 metastasis, but there are some other study that shows that maybe even up to 5 metastatic disease process in the lung, we're able to intervene with a good result. And then other factors we look at is hilar lymph node, like those what we call N2 lymph nodes. If those are involved, then patient prognosis tend to be much worse. So in terms of not surgical outcome, but their overall survivability down the road. So in those patients, we're much more hesitant about intervening on those patients. Maybe next slide, please. So let's say you see a surgeon, because these patients who had achieved stability will most likely talk in your multidisciplinary tumor board and said, will be a sort of candidate for consideration. Then you may see, radiation doctor or surgeons. And I think, I think radiation is great too, but I mean, surgery, I think one of the positive thing about it, I would say, is, one, we get the tumor out and we provide an ample tissue for analysis. We don't have to do a percutaneous biopsy or something like that. Second thing that we do a very thorough lymph node resection, removal on this. So if there's a hidden lymph node that's within the lung or a surrounding airway, we're gonna actually remove that for better staging purposes. So type of operation that you may discuss with the surgeon is what we call segmentectomy, which is the lungs are made up of several segments, which is less than a lobe. So for instance, upper lobe has a 3 segment, middle lobe has 2, lower lobe has 5. Depending on the size and extent of cancer, we could offer lung sparing operation, especially those with poor lung function. A lot of majority of these patients will get probably lobectomy, which is right lung has 3 lobes, left lung has 2 lobes. It's what we call anatomic resection. And finally, pneumonectomy. I mean, it would be kind of rare for a surgeon nowadays to do a pneumonectomy, but certain cases that let's say we want to really achieve a R0 resection, meaning completely removing the cancer, we may offer it. But as a surgeon, we like to try to preserve as much of lung function as possible, because removing that much lung, patient will be much more short of breath and their quality of life will be kind of poor. But whatever the type of operation we're gonna recommend, our goal is to try to remove all the lung cancer that is clinically visible and microscopic visible as much as possible. Let's say we think that we're not able to remove everything, then surgeon really should not be operating on you. Next slide, please. So, and then we're gonna talk about, well, then how we're gonna do it, right? So Olden days, we did an open thoracotomy, meaning you get a big incisional size, you crack your chest open and open it up, and then remove the tumor. It's a very safe operation, but it does associate with a lot of pain and recovery, right? And if you were do that on 30-year-old, 40-year-old, it's okay. I mean, patient will survive and they'll recover. But if you try to do it on patients 70s and 80s, even up to 90s, and maybe with a bad lung function or comorbidities, you'll be very hesitant to offer that operation. So then, 80s and 90s, this advancement of what called VAS, or video-assisted operation, happened where instead of making a big incision, they started making a small holes, and then using this sort of very rigid chopstick kind of instrument, then you're doing this sort of operation to remove it, which is a very good operation. And when I first came out practice back in 2012, I was doing that kind of operation too. But these are much more challenging, especially trying to get a very good lymph node removal and so forth. And then finally, robotic surgery. I think majority of lung cancer operation now in the United States are performed using a robotic surgery. This is really good for, we're making a very small hole about this big, using that kind of instrument that goes into the port, and then using a robot to do the, what we describe segmentectomy, lobectomy, hopefully not pneumonectomy. Next slide, please. So, and the patient said, what do I expect? Like, what are the results, right? So this is actually our experience at Northwestern, looking at those patients who underwent this sort of operation. So we're actually able to get these patients for all across from stage 1 to stage 3 patients. When you look at it, about a third of our patient right now goes home within 18 hours. There's some patient who actually will go home the same day after anatomic resection, right? And then average length of stay is about 1 day. Now, obviously, there's some outliers, right? But median average length of stay in our hospital is about 1 day. And our 30-day mortality, since I started, I came to Northwestern about 7 years ago, has been 0% for routine lung cancer operation, right? So that's remarkably different than what it used to be, right? Rarely, if ever, we give blood product. Those are what we call, we consider that as a complication, right? So we're trying to, the surgery has advanced far enough where now we could be much more aggressive about offering a surgical resection for these kind of patients, as long as the disease is stable, it's localized into the lung. Next, please. So I think that was it. Yeah.
My battery died.
Here.
I think the main message today is cancer is complicated, right? and we're just talking about one subtype of lung cancer. So a message that really needs to get out here is that you are best off getting at least a second opinion from a lung cancer specialist. There are many oncologists out there that have that treat all kinds of cancer, from leukemias and lymphomas and prostate cancer. But lung cancer, even this one little subtype of lung cancer, is extremely complicated. So at least a second opinion is important. And I guess I'm supposed to talk about ADAURA. So targeting a cancer multiple ways is often the best way to eliminate it or reduce the chance for recurrence. And so ADAURA was a trial that looked at combining surgery with the targeted therapies, and whether giving targeted therapy, osimertinib, after surgery was improved outcomes. And the answer was it did, dramatically improved the progression-free survival of patients, and actually there was a overall survival benefit as well. Now, one issue with this study is they did not provide osimertinib to the people in the control arm after progression, which I think was a bit of an ethical problem, which I complained about from the beginning, but they didn't listen. But this, I think, is now the standard of care, that there was an 80% reduction in the probability of recurrence after surgery for EGFR mutant patients. Another thing to realize with this, though, is about 30% of patients in the control arm never recurred at all. So they didn't get osimertinib and they didn't recur. So we yet do not have the ability to figure out who needs the osimertinib after surgery and who doesn't. But I would say today the standard for the common mutations is to give it. Other downside for this therapy is cost. This is given for 3 years, and it costs a couple $100,000 a year and does have chronic toxicities. And like I said, 30% of patients didn't need it. But overall, people benefited. Next slide. So that's also true after chemoradiation. This is the LAURA study where they took stage 3 lung cancer curatively treated with chemoradiation, and it was followed by osimertinib, also showing a major improvement in progression-free survival, 39 months median compared to 5 months median. Which really, and an interesting aspect of this study is if you just look at the control arm, these are patients with stage 3 lung cancer treated with chemoradiation. That's a standard approach. If you take all lung cancers, all stage 3 lung cancers, not EGFR, about 30% of those are treated with cured with no additional therapy. Yet EGFR mutant cancers, if you don't give additional therapy, there's only about 10% were effectively cured. So there's something about the biology of EGFR that makes it more likely to recur after certain interventions like chemoradiation. All right, next slide. And one last thing I want to mention before we go to the break. I know you guys are all glazed over from everything that's been thrown at you. But we talked about second-line treatment and what to do, oligoprogressive disease. I personally would like to figure out how we cure this thing from day one, how we don't worry about progression. Every cancer cell in your tumor has an EGFR mutation, yet it's very clear when you give these targeted therapies, you kill most of those cancer cells because the tumors shrink. But there are some that are still alive, they still have the EGFR mutation, and for some reason they're not killed. And so my lab and several others are intensively studying why you don't kill that last kernel of tumor cells from day one. I personally had lymphoma 25 years ago, and when they started treating lymphomas, you would use Cytoxan, and the cancer would shrink, but it would always come back. But then they figured combination therapies that would cure it, and I got a 4-drug regimen, and I'm cured. So what I would like to do is use science to figure out how that little kernel of cells doesn't get killed with Tagrisso and kill those cells specifically. And that's, we have a clinical trial that's just finished phase 1 with one candidate combination that we're working toward that. So anyway, you've been listening to lots of talking up here. So let's take a break and submit questions.
If everybody could take a seat right now, we could start the Q&A. We have about 30 minutes. It's going to be cut short just a little bit, but that's okay. So the good news is we got a lot of questions from everybody in the audience, a lot of questions. What we're going to do is we're going to start, Dr. Fiddler's going to start with asking some general questions that kind of people ask that kind of fall into the same type of category. So she'll start with those questions, and then we'll see how much time we have. If there are questions around the room, then, if you have a question, raise your hand. I do, want to point out that we are asking more general questions. We can't give, the doctors can't give personal advice or medical advice here. So, general questions are really what we're looking for. But we have about 30 minutes, and thank you all for your expertise.
Okay, thanks everyone for coming back. And so I'll begin with some of the more frequently asked questions to our esteemed panelists. We just to kind of a place to start, because there are so many things to talk about right now. There's a question about the repeat biopsy and how important it is to determine the mutation. And I know this was discussed quite a bit by many of us up here. But I think it's an important question to talk about, because what are the percentages of patients in our practices that are able to get that biopsy? How do we maneuver around it? When is it really important? And when do we make our best guess?
You talked the most about it.
All right, you want me to start? Okay, I can start, sure. So I think you can't understate the importance of a repeat biopsy. Now, oftentimes, there are factors where if it's just not technically possible, or if it's the cancer is only growing in the bones, for example, oftentimes if you biopsy the bone, you still can't, the way that kind of you decalcify the bone, that you process the bone to try to get usable information, it makes that molecular testing very challenging. But you still get histology, exactly, so you can still tell you if something looks different under the microscope. But no, I think really in almost all cases, and it's not, I probably can't give a percentage. I know that Zosia Piotrowska led the study that actually to look at on-treatment biopsies, and even in a formal trial format, I think it was only something like 40–50% actually got usable repeat biopsies. So it's definitely not always easy, but it needs to be pursued.
Well, it's also true that we're all coming from major academic centers where we have navigational bronchoscopy, and we can biopsy 1 centimeter nodules at the pleuro bronchoscopically, and these guys are amazing. A lot of the docs in the community don't have a ready access to an interventional radiologist who can do these biopsies. So that's a real problem in the country, and maybe that's a good time for a second opinion.
Can I add? So 2 things. First, I think I would definitely echo the importance of a repeat biopsy, if for nothing else than to get the histology, because this transformation, this change, this identity change from one type of lung cancer, non-small cell lung cancer, to another type, a more aggressive type, small cell, can occur in about 10 to 15% of patients who are progressing on osimertinib. So that is incredibly important, because it's going to completely change the pattern of treatment. I would say, what often happens with repeat biopsies in my scenario, and how I counsel patients is, we're going to get this repeat biopsy, we're going to look at the histology, we're going to send the genetics. I hope that we find something that's going to be informative for your care, but I also want to say, this is at the cusp of where we are, the cutting edge. We're not always going to find something that's going to inform your next line of therapy. And so I want to try to set the expectation that we're going to do this, we're going to look for something that's hopefully driving resistance to your cancer, but we may not necessarily find it, something that's obviously going to change your treatment, because this is really where the cutting edge is. So getting that repeat biopsy, I always try to do it whenever it's possible. I want to see if it's small cell transformation. I want to see if there's a new driver, a new change in the tumor that could help me inform my next line of therapy. But I want to also be honest and say, we may not always find something that's going to change the therapy. The last point I want to make is, while we always advocate for tissue, liquid biopsy is also transforming care as well. I would never advocate for liquid biopsy in place of a tissue biopsy, but liquid biopsy where we draw the blood and we look at mutations in the blood is actually completely transformed our practice within the last even 5 years. And there are tests now that are coming, and even in our clinical practice, where you can even see things like the percentage of adenocarcinoma versus small cell just by a liquid biopsy. Does that replace tissue biopsy? No. Is it used as an ancillary test? In my opinion, absolutely yes. And I would always get a liquid biopsy at progression also.
And then just one more thing is that, when we think about biopsy, we think about percutaneous biopsy with the IR or bronchoscopic biopsy, which sometimes gives a very important information, but sometimes, a lot of times after treatment, either after radiation or after some sort of systemic treatment, the tumors tend to be kind of sometimes fibrotic, and you're not getting a good representative of the tumor. Or there's a heterogeneity in tumor in that sometimes you with biopsy, you're not actually getting entire representative. So sometimes in the surgery may be an option in tough location. And we have actually seen patients where they did a biopsy and just adeno, and then entire specimen came out, and there's some small cell transformation or different histology of cancer within that tumor too. So I'm plugging my own specialty here. Don't discount the surgery, because surgery is pretty
That's why
safe.
you're on the panel.
Yes.
So that's a good segue to another question, and Dr. Kim's already speaking. I'm curious what the panel thinks. There are some questions about how patients should be followed and the roles of the cell-free DNA, and any insights in what is prime time, what's maybe not ready for prime time, and monitoring.
So my post-surgical patient, obviously I follow the patient for early lung cancer, and typically I get, CT scan up to 5 years, probably early on every 3 to 6 months, and then after that kind of lengthen out to, yearly. And then at 5th year, when, things seems to be stable, then I go 3 to 5 years after that. Now, oncologists tend to be much more shorter duration in terms of follow-up and in terms of intervals and so forth. Following with the sort of this blood work and circulating DNA to see whether there's local recurrence. Now, I know that there's a lot of studies now following our patients, especially those with kind of a high-risk profile. I do actually advocate for advanced cancer. Now, is this something that we should do for the earliest cancer? I'm not sure 100%. But these high-risk feature cancer or locally advanced cancer, I do think that there is a valuable information we could probably get.
So I'll push back a little bit from the medical oncology perspective in the sense that I think, and this is a topic for the hot topic later this afternoon too, so this is just a primer. But I think, in the localized, locally advanced setting where we don't know who needs more therapies, to David's point about, are you cured with surgery alone? And how long do we need to take osimertinib in this setting after surgery, after chemoradiation? We don't have the data yet, but perhaps that's a scenario where what we call minimal residual disease detection, but trying to detect cancer microscopically in the blood, can help inform who needs these treatments and for how long they need them.
Can I just add before we move away from liquid biopsy, we could spend the rest of the day talking about liquid biopsy because it's such a huge area, it's transformative, but I'll just say that not all liquid biopsy is the same, and so there are many, many, many different types of liquid biopsy. There is what we call genotyping assays, where it's just, is the EGFR mutation there or not? And then there's these different kind of liquid biopsy tests where we're asking a different question, this what we call MRD question, this minimal residual disease question, which is completely different than just asking, is the EGFR mutation there or not? And then there are tests that are tumor-informed, where they actually develop a personalized liquid biopsy assay based on your tumor. And then there are non-informed assays where, it's off-the-shelf kind of liquid biopsy. So this is an enormous field. There are like week-long meetings just about liquid biopsy. We could spend a lot of time talking about this, and maybe we should during the hot topic session. Like, what kind of liquid biopsy should I ask for even?
We will.
Awesome. Okay, I'm going to shut up then.
All right, so maybe Dr. Scott can take this next theme, and it's about sequencing. So questions were posed, did we see what kind of survival information do we have for people who maybe started on osimertinib and then switched versus people who started on the combination, and if there would be expected to be different benefits with different strategies.
Great. When you said sequencing, I was thinking genetic sequencing again. Sequencing different treatments. So you start on one treatment, and then what do you do when that one stops working? So I think, Josh talked a lot about this in his session, but what's important is that you have kind of an informed discussion with your oncologist, because this is a very nuanced area. So not all kind of progression is the same. It depends on how long you've been on a treatment, how long it's been working, how well it's been working, how well it's been tolerated, how long it's been, if you had a different treatment, how long you've been off of it. So there's so much nuance. I think in interpreting the data, there's one thing that we focus on a lot is what we call crossover, but really what it means is the exposure to a different treatment later on. And so that really gets to the question, let's say osimertinib plus chemotherapy. Well, if you get osimertinib and then you get chemotherapy, is it really better if you get them both together, or if you can be on the osimertinib and then wait till the disease progresses a little bit or a lot and then start chemotherapy? And these are questions that we try to answer in clinical trials, but oftentimes we really fall short of getting a clear answer to whether or not it's important to have that early exposure or to waiting until you have a later exposure. So sometimes we see Mariposa, the study of amivantamab and lazertinib, is a really good example of this, where we really haven't answered the question of whether that early exposure to amivantamab is the driver of a survival benefit, or whether patients would do just as well getting that amivantamab after osimertinib or osimertinib with chemotherapy. And these are really complicated questions. We all spend a lot of time trying to dissect the data and interpret it ourselves. So I think it's going to be an individualized decision for every patient, for every type of progression. If there's changes in the tumor, if there's mechanisms of resistance, it's such a complex answer, but it's a very good question. And now we've got more and more options than ever, right? And we've got kind of a second-line option and maybe a third/a different second-line option, and these are all kind of overlapping with treatments that many patients will have started to see in earlier lines of therapy now that we're using combinations. So it's rapidly evolving. Our current data doesn't represent our current standard of care, which has changed significantly over the past year, and so I hope I've expressed that it's a very complicated answer, and that's all I have to say.
Did you have something to add, Dr. Cobb?
I think you're accurately stating the problem, that it's complicated and every patient is different, and we just don't have the data. And you gave a great example of Mariposa and Mariposa 2. That's the trial where they gave amivantamab first line. That's Mariposa, and they showed a benefit. And then they did another study where they gave amivantamab second line after progression on osimertinib, and that also showed a benefit. But in their first line study, they didn't allow crossover to amivantamab second line. So, we really need to lean on those evil drug companies to do studies that reflect the way we treat patients in the real world. We have to give the control arms the experimental drug on progression, because that's what's going to happen. If you've got an active approved drug like osimertinib, you have to give it on progression in the control arm. If you have an active drug like amivantamab, you have to give it on progression to really determine what's going on. companies will push back and say, oh, well, we want to see what the survival benefit is. Well, I'm sorry, the real survival benefit is what happens when you give it second line instead of first line, and we don't know. So the data aren't there, and unfortunately, companies are very unlikely to do those kinds of studies. So we have to rely on the cooperative groups if they still exist.
Okay, I'll ask another question, and then perhaps we can open it up to the open mic for questions. Perhaps, Dr. Lovely, you can answer. Does your treatment choice, is it affected if a patient comes and they have brain metastases at the time of diagnosis or also at the time of a progression?
Yeah, so this is a very good and very important question because almost up to a third of patients with lung cancer will have brain metastasis, and that the probability of having a brain metastasis will increase with time. And so, as I mentioned, we want to have drugs that are very active in the brain, and the brain is a sanctuary site because of the blood-brain barrier. And so if I see a patient first, let me take a step back and say part of the staging for lung cancer is getting a brain MRI. And we're fortunate in the United States to have access to imaging studies like brain MRIs. That's not true in every part of the world. And so getting a brain MRI, incredibly important at diagnosis and for monitoring for lung cancer. It depends, and you're going to hear this a lot, it depends. And that's true because you can't, make a one-size-fits-all approach to lung cancer treatment. So if I see a patient who gets an MRI of the brain and they don't have symptoms, and I'm just getting that MRI to say, hey, I'm just going to take a look in there because that's part of what we do to stage lung cancer. If there's very, very small spots that are a couple millimeters in size, then I feel very comfortable just starting the osimertinib and letting the osimertinib take care of the spots in the brain. We have very good data that osimertinib is active in the brain, that can control brain disease. It starts to get a little bit different if a patient presents with things like headache, seizures, any sort of neurological side effects or neurological symptoms. Then I might be starting to call a friend in my radiation oncology to say, hey, a patient is manifesting symptoms from their cancer that spread to the brain already. Do we need to think about something called stereotactic radiosurgery or SRS, or sometimes called gamma knife? But even then, it's really nuanced because it depends on the size of the lesion, the location of the lesion, is there swelling around it, how fast can I get the drug? So this is really, and I think a very, very, very important message that we should continue to communicate is lung cancer care is not a single doctor. It is multiple doctors working in partnership. And some of them you're going to see, your medical oncologist, your surgeon, your radiation oncologist. Some of them you're never going to meet. The radiologist who's reading your scans, they are so important in your care. The pathologist who's looking at your tumor, they are so important in your care. This concept of having a multidisciplinary tumor board where we get together, and there's like often 50 people in this room or a virtual room talking about individual cases. We can't deliver the best care without working as a team, and that is happening every single day in the background. And so it's hard to distill, hey, this is what I do if I have a patient with brain metastasis, other than to say, I do think about it differently. I may phone a friend in radiation oncology. It depends on the size and the location of the brain metastases. In general, my practice is for patients who are newly diagnosed, we're thinking about a combination regimen from the start, or some kind of intensification, whether it's radiation and osimertinib, or osimertinib plus chemo, or maybe both of them. And the CNS metastasis or brain metastasis is just something that's very serious for lung cancer, very common in lung cancer, and is going to change my treatment planning for multiple reasons.
So one additional comment. So one thing we do have to be aware of is often you find a lung cancer, then the pulmonologist orders a brain MRI, and they end up getting, seeing 27 asymptomatic brain mets before you get genetic testing on the tumor. And that pulmonologist will send that patient to the radiation doctor right away, and they'll get whole brain radiation. And I think that's the wrong thing to do, especially in people without a smoking history. Those people need their genetic testing before they get whole brain radiation, because they'll often live long enough to experience the dementia from whole brain radiation. And that could be avoided completely with some of the modern drugs.
Yeah, I mean, I think this kind of gets to the point of importance of multidisciplinary management of these things, especially, this is very complex, right? It's not just, and so, a lot of times, your local hospital will have a tumor board. Just make sure that, your case get discussed, especially when it comes to local events or stage 4 cancer. And seek a second opinion if you think that there's a doubt too.
Okay, so we have about 10 minutes left, and we can open it up. There's some hands in the audience and a moving microphone. Hopefully, we'll get to everybody.
Oh, thank you. Hello. I have a question about tolerability. Many of us can't tolerate, who are on Tagrisso, osimertinib, can't tolerate 80 milligrams, but we do really well at 40. However, we also know that patients are reluctant sometimes to tell their doctors all the toxicities they're experiencing because they're afraid they'll be taken off the medication. They're not aware that they could do well at a lower dosage. I know there's many different approaches. I was wondering from each of you if you might say, do you tell your patients when they're starting treatment that if it's not tolerable at 80, they can move to 40?
So maybe I can start with that. So if you have metastatic EGFR mutant lung cancer, you're not going to be cured by osimertinib. So quality of life is especially important. And I have seen a case of an EGFR mutant patient back a few years ago who got erlotinib, got 2 weeks of erlotinib, had diarrhea, doctor stopped the drug and sent her to hospice. That's just totally wrong. Everybody's, the right dose for a patient is different for each patient. And you have to do dose reductions to improve the side effects. And these drugs are so potent that going from 80 to 40 is often highly effective. And every time it's been looked at, the people who have to dose reduce due to side effects do the same as people who don't. So I think it is important to adjust the dose for each patient for their own personal tolerability of the drug.
Okay, next question.
Hi, Mike Troy. These are going to be some tough ones, but I just ask you to hypothesize and just in terms of doing a little advocacy, because I think that's why we're here. Obviously, there's the COMPEL data continuing osimertinib post-progression. I think there's some initial data in the ORCHARD trial showing combination of dato-dxd, the ADC targeting TROP2 with osimertinib. I think the duration of response was like 20.5 months, which obviously swamps COMPEL. Now, with ADCs, you have much more toxicity. So I think, how do you think about those sort of off-label combinations? I mean, MET amplification, another one with Tagrisso-V. And in terms of kind of thinking in 4 directions, because I think patients are operating in this setting where you've imperfect information, and quite frankly, you can't wait for all the data to come in. And so I think the thing is like Tagrisso-V, if you've MET amplification, generally that occurs at baseline, and then upon progression, you still have it. Going on indefinite ADC is pretty hard. Have you thought, or is there any thought in terms of like a limited duration of exposure and sort of bringing that forward instead of like just COMPEL, where you throw somebody on chemo, to hopefully really get that duration of response or depth of response and extended benefit?
I can start with that one.
That made sense.
You should come sit next to me up here, though. That was those are very well said questions that we all have and that we think about a lot. And how do we combine medicine to control a very heterogeneous disease, especially on progression, where we know that different parts of the cancer are growing with different signals. And so ideally, we'd be able to continue everything together in the chance that, let's say, the osimertinib is controlling one part of the cancer. But unfortunately, oftentimes combining all these drugs together makes it harder for the patient. So it's really a careful balance between the benefit where it might be very small in continuing the osimertinib, where clearly it's not controlling all of the cancer, and it's never going to control the cancer forever, as Dr. Carbone just mentioned. So maybe we move on. But there are a lot of studies trying to combine these, like you mentioned, several of them, and I would say most of the ADCs are being looked at in combination. I think what I'm hopeful for is that we'll move these earlier, right, and we'll see these combinations for patients sooner. And again, as kind of we were saying, we'll find the right combinations and be a little more precise than we are now with just EGFR, and you all get the same combination, right? And we've got all the science that we need, or we don't yet, but we've got the tools to try to drill down and find which combination is right for which patient. We've already got a few options, but hopefully some of these new drugs, and a lot of these studies are underway, will be looking at bringing certain ADCs or other types of combination therapies earlier in the disease, or in our current state using our kind of informed assays at progression like biopsies and resequencing. You mentioned MET. I think that one's a little tricky because we do have some combination approaches that have been studied but not with Teliso-V, but with other drugs like savolitinib, tepotinib, amivantamab. So, you know, I think it's a very important question. It's going to be a careful balance of the toxicity of combining something to a TKI with another drug, and ideally more precision, moving it up front and increasing the benefit if we're going to expose more patients to it.
But also limit durations, and I find with some of the ADCs, just if they're not feeling well, skip a dose reduce, adjust like I was saying, or even, you know, if you're giving it first line, maybe a limited course, and then you stop. Maybe you've achieved the benefit.
Yeah.
Are we ready for another
Yes.
question?
I can send my question online somehow, maybe, you know.
Well, we have so many questions, which is great. We have
Okay, great.
So many questions, so I couldn't get to all of them, but go ahead.
Yeah, so the EGFR mutated tumors are often considered immunologically cold, and it's thought to contribute the poor response to those immune checkpoint inhibitors. But I want to ask you guys the perspective on the future directions of immunotherapy research and potentially for those individual approaches in patients who have progressed after multiple treatment. Because for, you know, we're talking about biopsy, and then we find a new mutation, and we add another treatment, but this seems after a couple of lines, it's rabbit hole, right? So basically you have more, actually you cannot use target. So therapy, what, you know, you think, like, I would still think the immunotherapy hold that promise for, you know, other mechanisms instead of just tumor cell itself. What your perspective on this line of research? Thank you.
Well, I just first want to, your question made me think of something important that we have not talked about, which is waiting to start therapy until you have molecular testing results back. I think a lot of the reflex, well, obviously you want to start quickly, but I think we like to say you want to get on the right therapy, not the fastest therapy. And I think when we get initial results back, your treating oncologist might say, and this was a question, and it's still a question that comes up, well, what if I have high PD-L1, which is a marker that can predict response to immunotherapy, and an EGFR mutation? Or what if I just see that high PD-L1? Should I start immunotherapy? The answer to that is no, because we know that's not predictive of benefit, particularly in patients with EGFR mutations or other driver mutations, where, to your point, there is what we call an immunologically cold tumor environment. It's not one that has as many of this foreign stuff that the immune system can recognize. Not only that, and we don't know exactly why this is the case, but if you start immunotherapy and then now we have the EGFR mutation, now we start Tagrisso, osimertinib, you can have really bad side effects that come up. So important to wait for those results. Now, to answer your question, I'd like to hear what others have to say here. I think we can't give up on immunotherapy for EGFR mutated non-small cell lung cancer, whether that's specific bispecific molecules where you really try to shepherd an immune cell much more directly to the cancer cell, or there's really novel and complex things, something called TILs, which are immune cells that are in the cancer, where, again, this has to be a right patient where there's the right timing, but those can be harvested, expanded, and then reintroduced to patients to try to kind of engender an immune response. So I think we can't give up on that hope because that's really what can create durability for a lot of patients, but it's still not prime time.
Just one added thing, another cancer that's got very poor lymphocyte infiltration and is immunologically typically cold is small cell lung cancer. But like was just said, the DLL3 bite drags lymphocytes into the tumor and really ends up with durable responses even in an immunologically cold tumor, because I think dragging the T cells in induces a more immune hot environment once you activate those T cells. So I think if we can start identifying some cell surface proteins that are specific to EGFR tumors and design, for example, bites, it would be useful. And in my lab, we're looking at a cell surface proteomic analysis of driver mutant tumors to look for specific cell targets for exactly that reason.
Yeah, I would just echo the enthusiasm for these BiTE therapies to drag the T cells in, but also add, these technologies like engineered T cells like CARs, CAR Ts, which have come into other types of cancers, but not into lung cancer as much yet. I think the EGFR field is ripe for that. I think none of us want to give up on the promise of immune therapy for EGFR mutant lung cancer, because in our patients who have other types of lung cancer, we see the transformative power of immunotherapy, and when it works, it's like miraculous. I mean, I'm sure all of us have in our patient panel patients who've received immunotherapy, gone off of it for stage 4 disease, and are alive years later off of drug. It's amazing, miraculous. And so we want that to come into the EGFR space. It may not look exactly the same. It may be different immune checkpoints. It may be BiTEs. It may be CARs. It may be EGFR vaccines, which people are working on. But I don't think that I echo your enthusiasm for harnessing the power of the immune system to help advance this field. We're just going to have to think about different ways to do that than the PD-1, PD-L ones that are there right now.
Okay, so we have time for one last question.
Hi. Okay, I'm going to address the elephant in the room. I'm a 9-year survivor, stage 4. Started with Tarceva and then on to Tagrisso. I don't want to. I appreciate everything you guys do, and AZ, AstraZeneca, saved my life, basically. However, and I'm excited about the T cell stuff, the immunotherapy T cell stuff. I'm excited about the persister. I know, Dr. Lovely, you've done some research for us on that, and I'm excited about Dr. Carbone's lab because I think persister cells are really something we need to start attacking. However, I know there are a lot of people in this room that are still on Tagrisso, and they are dreading having to go off of it because, let's be honest, the treatments after Tagrisso are very harsh, very, very harsh for some people. I think the bar is set very low because, when you're saying an extra 5 months, an extra 8 months or something, I mean, come on. I'm sorry, I don't want to offend anybody. But I just think that, I don't know, I wish we could do better, I really do, because I'm not looking forward to, when I go off Tagrisso. It's ugly, it gets really ugly. So I just wanted to, I know a lot of people in this room probably feel the same, and I want to just put it out there.
We definitely should not be. One of the disappointing things to me is these second-line therapies. We say, oh, it's a positive study, 5-month PFS. That's very disappointing. That is a very low bar, I agree, and we really should be shooting higher.
And I think, Oh,
I'm just saying, the problem, it's a difficult problem though, and it's not like we're withholding therapies that are better. We're doing our best to try to figure out better ones, but the bar should be cure.
And I think, why there is some expressed excitement about some of these new therapies with those numbers not looking very impressive at all, is because, we still aren't great at selecting the right person for the right therapy. And when you look at some of the patients, the median, which really is expressing, and I think it's probably in the glossary, is, if you take 100 people, it's the person in the middle. So those numbers sometimes look a little underwhelming, but I think we've all probably had some patients who have been on therapies that one would not expect great things if we just had the median, and some people can be on treatments for a long time, and it can be, life-altering and a good experience, and hopefully with tolerable side effects. But certainly there's room for improvement, as you addressed, and that's why we're all still here.
There's one thing actually we haven't addressed, and we're talking about cure, right? So, obviously when the cancers are much more advanced, it's very hard to cure it. But, a lot of these EGFR mutated patients and so forth, especially in Asian population, they're non-smokers. Current right now, a way we are screening patients based risk-based, right? They're smoking, smokers and so forth. There's this criteria that's set. But a lot of patients, about 20% of my patients will come in, no history of smoking whatsoever, no cancer history. So just want to put it out there that maybe in the future, way we're screening our patients should be not based on this risk profile, but maybe based on age or some other criteria. If you have a family history, for instance, in Taiwan, because there's a lot of non-smoker related lung cancer, they're going by the risk-based model where if you have family history of lung cancer, then you're getting screened at 35, regardless, right? So those are the things that I think we have to kind of think about. And a lot of you guys have family members, let's say you're a non-smoker, have a lung cancer. Your family members may be, and there are actually this study, including Northwestern right now, we have a much more of a broad population base, especially a non-smoker related cancer, where their family members needs to get screened. So that's something that I think we should think about, screening our patients, in general, high-risk patients, but also think about those patients who are not currently under the guideline, but maybe have a family history of smoking and so forth.
Lung cancer is the only cancer where we don't screen everybody. We basically prostate, breast, colon, everybody gets screened. But there's been a specific attack on lung cancer screening for false positives and unnecessary surgeries. But those worries were 30 years ago worries.
Exactly right.
So today, the way we work up nodules and the way we intervene and determine if they're cancer is so much better than when the original studies were done.
The functional criteria is like 1980 studies, right?
And the lung cancer screening is a very low dose of radiation, takes 10 seconds. You don't have to do a bowel prep. You don't have to smash body parts.
It's less radiation than an airplane, right?
It's so easy to do that I think we really should broaden the criteria, and I don't think personally think that we should be limiting it.
And everybody getting colonoscopy at 50, right? Right? And people, and how invasive is that, right? But yeah, CT scan takes what, 10 minutes?
The other thing is that at our institution, we are diagnosing more early stage lung cancers with incidental nodules that are detected from CT scans of your belly from a car wreck that covers a little bit of your lung, and you find a lung cancer there, or cardiac calcium screening or other tests. And basically that's CT screening for people who've never smoked. So, and those people aren't dying in masses because we find these incidental nodules and are resecting their lungs inappropriately.
It's a stage 1A lung cancer. I mean, if it's pure kind of ground glass with a tiny bit of a solid component, 99%, those are like when you take it out.
In Japan, I was just at the Japanese Lung Cancer Society meeting, In Japan, they basically do a CT of everybody.
Yeah.
In Japan, a screening CT costs $38, and it's covered by insurance, so the patient only pays $3 for a screening CT.
Well, what could come, what could come.
And they detect, and most of the lung cancers detected in Japan are stage 1.
On that positive note for lung cancer screening,
Can I? Can I make one really quick comment?
quick, yes.
One really quick. Sorry, I'll be really quick, really quick. I just want to say, like, none of this research equals cures, but we can't have research if we don't have funding for research, and funding has been really compromised this year. And so your voices as patients are more important than ever. This is incredibly important. Please use your voice to advocate for research. I frequently get told on my EGFR grants that EGFR mutant lung cancer is a solved cancer, which is clearly not, but that is a critique that happens. So please use your voices to advocate. This really requires a village to continue to push for these cures. Thank you so much.
Thank you. I hate to move us on, but we want to stay on schedule. But I do want to say, and I know some people probably don't like this description, but fighting cancer is a team sport, and this is an amazing team who is on your side, as well as that team. Yeah, I mean, I feel like now if I was to walk into the doctor's office, I'm going to picture all of your faces with me. Seriously. Okay, so this morning's session was so much information, and I'm sure very overwhelming for many of us. I have to say, learning the history again was incredible and very important. But I do want to move us on to the next session. We're going to skip the break because we had a longer break earlier. And also I want to address, I know you have so many questions. Many of you submitted questions that we did not get to. We will do our best to try to address those and get those answers out to the community as soon as we can.